Okay, so our final talk for this conference, still under ethical issues, will be given by Professor Tan Maw Pin on the right to care of older people with serious illness. Where is the gap? Professor Tan Maw Pin is currently a professor at the Division of Geriatric Medicine, Faculty of Medicine, University of Malaya. She also holds many other posts, some of which are President of the Malaysian Society of Geriatric Medicine, Medical Director of Managed Care, Sdn Berhad, Honorary General Secretary of the College of Physicians of Malaysia, Managing Director of ACT for Health, Sdn Berhad, Medical Director of Genting Dementia Daycare Centre, and Deputy Director of Centre for Innovations in Medical Engineering, University of Malaya. Let us welcome Professor Tan Maw Pin to the stage.
Hello, everyone. Thank you for the opportunity to actually share with you some of the issues that we encounter when dealing with the end of life of older adults, particularly in Malaysia, but I'll also cover some of the principles when it comes to end of life care for older adults in general. The title I was given today is The Right to Care of Older Persons with Serious Illness. Where is the gap? In fact, we have a blank canvas here in Malaysia. So rather than addressing the gap, perhaps it's more important to actually highlight the issues that we encounter day to day and potentially the differences in end-of-life care for older adults compared to what the hospice movement regularly encounters with end-of-life care in dying people in general, particularly people dying of cancers. So first of all, I'd just like to introduce you to the idea of population aging. I'm sure now that we have now reached 2022, most of you are acutely aware of the issues with population aging. And Malaysia was going through what we call a honeymoon period for the last 20 years in actually benefiting from the demographic dividend, that is having fewer children, but also not many older adults, and therefore a bulge in the population within the productive age groups. We have squandered those 20 years, and we have now arrived at the steep side of the exponential curve of population aging. And these figures are scarier than anyone would ever imagine. And unfortunately, many of our politicians, our policymakers, and most healthcare professionals I know still have their head buried very much in the sand like ostriches and not accepting this as a reality. So what do I really mean? So basically, our population, if you look at this is the current population estimates actually released by the Department of Statistics of Malaysia in 2016. In fact, after the 2020 census, the situation is actually much worse than this. So this is actually an underestimate. And in 2020, Malaysia crossed the line for aging population, in 7% of its population being aged 65 and over. So in 2010, we had about 2 million, roughly about 2 million people aged 60 and above in Malaysia. By 2040, this will not even have doubled. It would have quadrupled to nearly 8 million. So basically, unless we do something very quickly, we will be in deep, deep trouble in the next 20 years. And this is why population aging is very, very much a problem of developing countries, and particularly the middle income countries. So Malaysia is very much stuck in the middle income trap, and therefore acutely now feeling the issues of population aging. So when we talk about growing old, that makes us much closer to death. And in older people, the conditions that affect older people are quite similar to the population in general, but there are slight differences in that diseases such as dementia becomes more prominent, as well as arthritis. These are what we tend to call degenerative diseases, but we now know that they really should be considered as non-communicable disorders. And this is actually the statistics published by the National Council on Aging, which actually highlights the 10 most common conditions affecting older adults. And yes, hypertension affects older adults a lot, but people don't die of hypertension. They die of strokes, they die of heart disease, they die of dementia. And this, in fact, is beginning to emerge as a reality. So in the United Kingdom, they have spent many decades dealing with accurate death reporting. And in 2020, it emerged that with accurate death reporting, dementia has by far outstripped all the other causes of death. And this was updated in February 2020, highlighting that dementia is now by far the commonest cause of death for all age groups in the United Kingdom. And it's unlikely that it is going to be any different in any other country. So even with the COVID-19 pandemic ravaging the United Kingdom and the very poor performance and a high mortality rate from COVID-19, dementia still outstripped all other COVID-19 and ischemic heart disease as well as the most common cause of death in the United Kingdom. And dementia is very much a disease of older adults. So in Malaysia, dementia doesn't feature as a cause of death because it is undiagnosed. It is there's a complete lack of awareness, and despite our best efforts, there is no commitment to cognitive screening. We do know that if you're over the age of 65 and you're admitted to hospital, you have a 1 in 4 chance of having cognitive impairment, either due to delirium or dementia. And if you're over the age of 80, you have a 1 in 2 chances of actually having cognitive impairment. Yet we listen to everybody's heart, but we do not screen anyone for cognitive issues. So this was published very recently by the Department of Statistics of Malaysia. So in comparison to the UK figures that I just demonstrated, COVID-19 actually appeared as the most common cause of death, accounting for 20% of all deaths in Malaysia in 2021. And ischemic heart disease used to be labeled as the most common cause of death, followed by pneumonia. I put this to you. If someone has dementia and has never had it diagnosed, what do you think gets put down in their death certificate as the main cause of death? Old age features a lot, of course. And if you looked at the causes of death for people over the age of 65, then old age is probably number 2 or number 3, with pneumonia as number 1. But in fact, most people with dementia die of pneumonia, but the primary cause of death is actually dementia, but it's just not recorded. Ischemic heart disease is an interesting one. In fact, this if you died of a cardiac arrest, if your death certificate says cardiac arrests, then this would actually be classified as ischemic heart diseases. And unfortunately, far too many of our death certificates actually state cardiac arrest. So why do I emphasize so much on the lack of reporting of dementia in our country, and when we consider that most people in UK and many other developed countries already die of dementia, and dementia probably accounts for far more deaths than we ever imagined in Malaysia. This is the trajectory of the different causes of death. So people in palliative care land will be very familiar with cancer trajectories. And in cancer trajectories, this is function. You maintain a really high level of function throughout your active treatment phase, and you only start losing function when the disease escapes any benefit of potentially curative and also palliative life-prolonging treatment, and heads towards palliative care, and you actually have quite a steep trajectory, a brief period of terminal care, followed by death. So it's very well defined. And in fact, nowadays, if I had a choice, perhaps I would choose to die of cancer. Because this is the trajectory that is less desirable, as many people would say. This is a trajectory followed by people with organ failure, such as heart failure. So they have acute exacerbations and a gradual decline of overall functions. But this is the trajectory of someone living with dementia today. And it needn't be like that. There are ways where we could actually push them up towards the cancer type trajectory, but there's very little pursuit for that to happen. So what happens is the function is lost at a very early stage, and they maintain a very low level of function with unpredictable periods of decline, and eventually a very long lingering death. So what's the difference between prominent symptoms at the end of life? We're all very familiar with cancer symptoms, pain being very prominent, shortness of breath, weakness, psychological distress, difficulty eating, anorexia. But when it comes to dementia, the symptoms that we actually encounter at the end of life with dementia are dysphagia, which are very prominent, leading to a lot of ethical issues and a lot of undignified treatment. Dependency, behavioral issues, screaming, shouting, aggression, difficulty with communication, and hence nearly all of our dementia patients don't have no decision-making capacity as they near the end of life, and this period can be very long. And of course, the nearer you are to the end, being very immobile, leading to the increased risk of pressure sores also becomes a huge issue. But perhaps the last one isn't so different from cancer. But this is what we often forget. The older person actually, once they reach the age of 18 now, the age of consent, is considered an adult. At no point does the law actually allow another person to make decisions on their behalf. In fact, our country does not even have laws that look at loss of mental capacity, and we very much rely on the Mental Health Act to actually address issues with capacity, and which does not necessarily address issues of loss of capacity with medical treatment rather than psychiatric treatment with loss of capacity. And there's also nothing to address financial management and decisions on social care when it comes to loss of capacity. And very much a lot of ageism is what we see in healthcare and also society today. We often see rationing of treatment, particularly during COVID-19. No one above the age of 65 would ever be afforded a ventilator anywhere in the world when there was short. And it's actually horrifying and despicable that decisions are made purely by the number of years you've been on this world, not with intrinsic capacity and likelihood of recovery. So often in our country, particularly, older people are denied the right to consent. So usually when the older person gets admitted to hospital, it is expected that they're accompanied by a younger family member. The patient is actually not communicated to, either in terms of history taking or in terms of information about the diagnosis, as well as what's going to happen, as well as treatment decisions. And consent is taken for granted without even considering the older person's mental capacity, and taken directly from the next of kin. It is grossly illegal, but no one stands up for the loss of rights for the older person. And this actually really impinges on the confidentiality of the older person, because they have not actually given consent for someone to speak about their medical issues with a relative. And many of these people actually, even if they have cognitive impairment, still have a right to privacy and confidentiality and have consent-making capacity. There's a lot of collusion. So family members actually tell doctors not to tell the patient the diagnosis, and the patient remains ignorant of a diagnosis of cancer or any other terminal condition like dementia, right throughout their illness courses. So autonomy is so much of an issue that often we don't ever consider what the older person's wishes are. Our country does not actually mandate enforce advance written directives simply because there's no law, but there's nothing stopping them actually having written advance directives. And if there was one, the patient's relatives, the doctors, it would make doctors' life much easier. An older person often leave advanced verbal directives, but unfortunately, when they are unable to communicate their decisions, but even when they are able to communicate their decisions, we actually seek the surrogate decision who does not necessarily makes make the decision according to what the patient would have wanted, but very much follow the desires of their own heart. Doctors often take a paternalistic role and make a best interest decision for these older persons as well, without taking into account whether they have decision-making capacity or not. An older person very much often are denied the right to die and the right to dignity, with the use of restraints being very common, even though this is actually deprivation of liberty and actually in violation of someone's basic human rights. We have issues also with relatives, and every one of you would identify with the daughter from California, in that basically this started with a case report in 1991 describing a specific stereotype of unfortunately it's usually the daughter who have lived away for a very long time, and actually demanding treatment when it is considered futile and acting in an aggressive way and impeding management of cases. And this is very much issues, particularly in Malaysia, where there's a huge amount of international as well as internal migration, with daughters living away from their parents, and when the parents falling ill, taking time off unpaid leave to return to their parents' side, and demanding treatment that is considered futile or unlikely to be of benefit by the medical team. And this often leads to conflicts. So the conflicts that arises when we look at end-of-life care for older adults are artificial nutrition and hydration. We all know this. Unfortunately, all too often, the nasogastric tube is inserted in the emergency department, and sometimes we even have issues with artificial ventilation. But fortunately, this occurs less often. But definitely, nutrition, because it's so emotive and plays in such an important, given such important emphasis in our culture, continues to plague us. Older people now have no place to die. Often they are not voluntarily admitted to institutional care, and the house is sold and they move in to their children's houses, and therefore people do not want them to die in their homes, whether it's a private nursing home or whether it's a private residence, and they end up having to come to hospital to die. But hospitals do not afford them a place to die either, because we need the beds for people who need to live. And then there are also issues with recurrent admissions at the end of life related to the issue that nobody wants them to die in their place. And unfortunately, with recurrent admissions to hospital, you then have the issue of inappropriate use of antibiotics, and using older people as the breeding grounds for multi-drug resistant organisms. So these are just some of the conflicts that arises at the end of life, and some of the gaps, if you like, for treatment of older adults at the end of life, particularly older adults with dementia, which has emerged as the most common cause of death worldwide, possibly. Thank you very much.
Thank you so much, Professor Tan Maw Pin. I'm sure many of us can relate to Professor Tan's talk, as many of our patients fall into the category of elderly people, and a significant amount of these elderly people with dementia as well. And so we can examine our practices and see whether we are aligning to the best practice, and also addressing the ethical dilemmas that can occur in this special population. I can see some questions already there, so we will now move on to the Q&A session for both Dr. Tan Hui Siu and Professor Tan Maw Pin.